Thank you so much. And it is my great honor to give a lecture in the İzmir online neurosurgery meeting. And this is my second time online lecture. And today my lecture topic is some full endoscopic approach for management of cervical foraminal pathology. Maybe I have more than 300 cases of cervical endoscopic procedures, and I have more than 20 years endoscopic procedures and more than 10,000 cases of endoscopic spine surgery. Among them, maybe I think that maybe 300 cases included in the cervical, and also maybe I started the new hospital of Harrison Spinatus Hospital Cheongdam, and after then I'm done, or I already done already about 150 cases operation, and all done by the endoscopically, not open surgery. It means that they're included in the cervical, thoracic, and lumbar, decompression, discectomy, and fusion, and multi fusion also all include that. I mean that maybe I think that maybe the final step of the endoscopic spine surgery to spreading the generalization, like some generation change from open surgery to endoscopic spine surgery, is finish the cervical thoracic and the lumbar interval fusion. And that is because of that this lecture is very important to establish the generation of the endoscopic spine surgery. And also you can see here two paper of my paper. This is very important because of that. This one is rationale of the posterior endoscopic cervical foraminotomy, the long-term clinical result, and one another is that some new technique is to performing the cervical posterior foraminotomy safely. I naming that partial pediculotomy, partial vertebrotomy technique. But nowadays, so many endoscope surgeons who doing the posterior approach, they doing the like this partial pediculotomy and partial vertebrotomy approach, because I recommended this two paper to based on today's lecture. Yes, this is my new hospital. Yeah, we already knowing that we because of that with the increase the people's mean life, we also met so many patients, degenerative disease patient came to clinic and they need a treatment, and sometimes they need operation, and also cervical pathology. Also, so many patients increase so much. But we before time we doing the anterior approach mainly because of that posterior approach have open cervical posterior approach very big obstacles, and disadvantage. The advantage of that some large skin lesion with paraspinal muscle damage can make lumbar loss of lordosis and especially kyphosis. And second point is that some posterior approach of the open surgery usually not easy to manage the details of the pathology, like disc protrusion, due to not only small operation field, but also there have so abundant bleeding, venous bleeding point there. Because of that, many doctors they doing the anterior approach rather than the posterior approach. But unfortunately, we already doing the so many anterior cervical procedures. I'm also done so many cases of anterior cervical operation, like some HDF and ADR, and sometimes some like a corpectomy. But we know that there have so many kind of complication, and sometimes that is very disaster to the patient because of that. And also some another point is that in spite of the well fusion and well established the patient pathology in the long-term follow-up, it makes some secondary problem of junctional problem and recurrence, and so many problem happen in anterior cervical approach. Because of that, you can see the this paper also, this paper of the Epstein also, they talking that the complication, it's so many kind of complication. We already well known that some not only hematoma but also there are myelopathy and carotid artery injury, esophagus injury, recurrent radiculopathy injury, and so many kind of complication maybe happen. And because of that, sometimes so many surgeons not choose the anterior approach easily. But if we can possible more safely and more minimize the option, not only posterior but also in anterior. Anyway, we can doing possible. We can more easily manage the patient, access to the patient. That is a more good chance to the patient to return to their normal life. Because of that, if the patient have some pathology like a cervical, lumbar, and anyway the thorax, that problem not solved a long time. It make some additional problem like some increasing the instability and aggravation of the chronicization of the sympathetic channel. This maybe some distortion like that. So many complications happen, and therefore I think that maybe recently with the development of endoscopic spine surgery, if we met the patient and like some problematic point, as soon as possible treat the patient like not only non-operative management but also operative management like endoscopic spine surgery. That will be more good life to the patient, in my opinion. Anyway, because of that, we know that to decrease this problem, endoscopic minimized option treatment developed before a long time, like some partial anterior foraminotomy approach, and so many kind of minimized option approach. But I think that maybe after with the development endoscopic spine surgery, there is nowadays a near change in the generation from the anterior to posterior. I already mentioned that maybe during last 3 or 4 years, maybe my cervical operation increased so much increase, maybe monthly more than 10 cases, but maybe I think I remember that maybe HDF maybe per year only 1 or 2 cases. Near all patients by the endoscopic posterior foraminotomy can manage that. And because of that, I believe that nowadays the generation of the cervical pathology changed from anterior to posterior by the endoscopically. And now so many Korean endoscopic spine surgeons, they doing the posterior cervical foraminotomy. And also we know that the endoscopic cervical approach firstly started from the anterior approach, because of that at that time the surgical screen was not developed, and but also the surgical instrument, especially endoscope drill, is not developed at that time. Because of that, the only limited anterior approach at the initial time from started, but we know that there have in spite of the endoscopic procedures, the anterior approach still have so many complications like some major organ damage injury like carotid and esophagus, and but also there have some still remain the recurrence and kyphosis problems still happen that case in the anterior approach. And more importantly, anterior approach only limited indication. Because of that, so many doctors, endoscopic spine surgeon hope to approach from the posterior approach, but unfortunately, during so long time, the endoscopic cervical posterior approach was not developed so much. Because of that, first problem is that the instrument is not sufficiently special endoscope drill. But nowadays we have so many good drill and so many good ablation system like RF system, And because of that, and also now there's so many good surgical technique introduced, like Helsinki. And anyway, nowadays many endoscopic spine surgeon approach of the cervical, mostly they doing the posterior approach. Today we will discover about this. And also you can see here the some paper of the Jin Sung-Luk Kim. He talking that maybe all complication of open anterior cervical surgery are possible with the ventral PECD. It means that the similar complication happen in the anterior approach. And also some another paper, actually, but historically, firstly, anterior approach started from first time. But do you know that at that time, this paper may be written by the 2007, but at that time, oh sorry, this paper 2007 anterior approach. Sang-Woo Lee write this anterior approach, but at that time, 2007, Dr. Rayten writing the posterior approach. I mean that the anterior approach and posterior approach history is near similar, but only at the initial time, anterior approach is more famous, but nowadays it moved to the posterior approach. And anyway, Dr. Rayten is my teacher, and Rayten firstly introducing the posterior cervical foraminotomy, but that technique is not spread widely, only some limited doctors doing the cervical posterior foraminotomy. But I believe that maybe this V-point paper, this paper, right, by the Dr. Chiang Kim. Nowadays we know that in the cervical area, first point, docking point is V point, because all doctors knowing that it is V point. But maybe after introducing this V point, the cervical posterior approach more trial and more many doctors apply, and more good result can take after this V point introducing. And also this also very important, maybe this is my paper, maybe here you can see the 3+ the technique of cervical traction. Because of that, at before time, we tried the Mayfield head clamp and some kind of head clamp to traction of cervical area to expose the some low cervical and to expose the more wide space. But because of that, it looks like a very heavy operation, very hard operation, large operation. But nowadays, after introducing this 3+ technique, nowadays we do not try the head clamp or any kind of instrument to cranium. Because of that, the patient receives more easy easy operation to the patient. Because of this 3+ technique is very important. This I've interested in this technique maybe 2018 to general minimal invasive spine surgery technique. And some another paper like this, Dr. Yuki talking that maybe some compared to the anterior, finally nowadays many people talking that the anterior rather than the anterior approach, posterior approach more good to the solving the cervical problem. In this paper talking like this, that point. And also Dr. Lan talking that this is also very important. Lan talking that maybe after endoscopic cervical foraminotomy from the finite element analysis, the cervical vertebra after PCD posterior approach treatment showed good biomechanical performance and stability. Maybe I'm also writing the many paper of cervical posterior foraminotomy, and recently I studied for the facet damage and instability. But in spite of the more than 50% and 60% of the facet damage, instability not happen. Because of that, I think that maybe that preserve the skin, muscle, and all structures. Because of that, the stabilization, not aggravation after, in spite of more than 50 and 60 and 70, some of patients 80, not instability happen. That is true, I will show. That is very important because of that. After sufficient decompression, the patient can solve that problem. And in spite of that, the patient should keep their stability and should return to their motion normally. Because of that, that policy is very important. And also this we know that maybe in the cervical posterior foraminotomy, we firstly docking the V point and widening this area. There is a conventional cervical posterior foraminotomy, but maybe 2020, I introducing partial pediculotomy and partial vertebrotomy. This technique is like this. Maybe you can see here. So many textbook and paper you can read this technique, and you see here sorry, like this. Firstly, this is conventional cervical posterior foraminotomy, but usually in this situation, this rupture, this can sometimes axilla and sometimes shoulder. That is not easy to manipulation, and some of patients like a severe foraminal stenosis cases, that is not easy to management at this situation. But if we doing more widely some partial pediculotomy and sometimes partial vertebrotomy, that make us a more wide space to working. That in and you can see here the here is near close to the foramen. Because of that, the foraminal decompression also can possible near completely in spite of the posterior approach. Because of that, maybe in the cervical area, mostly pathology located in the foraminal area. Because of that, maybe if we manage this area, foraminal area completely, maybe the anterior approach maybe decreases so much. I already mentioned that maybe my surgery of the anterior approach may be less than 5%, less than 5, less than 5%. And okay. But in the cervical posterior approach, we should consider the many kind of anatomical consideration, maybe. But this is very simple. We already know well known that maybe pedicle to pedicle, close to there, some nerve roots passing through this area. Because of that, maybe if we doing the conventional vertebral approach foraminotomy, maybe very close to the nerve area. Because of that, sometimes the walking is very difficult and sometimes nerve damage maybe happen. But if we make a more widely, like some partial pediculotomy and partial vertebrotomy, we can reaching the nerve root more safely and more widely. And also, this also very important that maybe conventional cervical posterior foraminotomy, the operating point is direct from the ventral dorsal portion of the nerve. But if we make a more wide area of the partial pedicular PPP, we can make a more less angled approach and then make a more safe approach to the target point, and more safe retraction is possible. And I already mentioned that the V point. Here you can see the docking of the V point. Now, this is another very important point, is that maybe you can read this concept in the neurospine from my paper. And we know that maybe with the increase of people's age, the human beings maybe degeneration, not only skin, but also there you can see the vertebral body. And because of that, you can see that this younger patient and older patient viewpoint is different. Maybe younger patient viewpoint is more lateral, but with the age, the viewpoint is close to the more medially. You can see here. You can see this concept in the Neurospine Journal. And another important point in this paper, you can see some spinal cord also some change like this with the age in more wide laterally. Because of that, in the older patient, maybe they have a more V point cross more centrally, but spinal cord spread more laterally. Because of that, the cord injury chance is more and more and more higher, and especially above the C5 4-5 level, the spinal cord is very close to the V point. Because of that, if you approach it from more than above L4-5, C4-5, you need doing the wide foraminotomy firstly and make a more lateral foraminotomy, then approach it. That can possibly more safe. But if not that, maybe like some conventional viewpoint drilling, maybe that is very risky, very close to the dural spinal cord area. And also in the cervical foraminotomy, we always met this two double root like area, but actually this one is sensory, this is motor. Actually, motor is located more ventral and more lower area, and the upper area is sensory area. You can see like this two nerve, but actually this is not two nerve. This is one nerve. One is motor, one is sensory. And also, this is very simple concept. Maybe the rupture disc, maybe sometimes the shoulder and sometimes axilla and sometimes combination. Also, this concept maybe I published it in the Turkish textbook of endoscopic textbook. I don't know the. You can see this textbook, this textbook published from Turkey. You can read this concept. And also another important anatomical relation is vertebral artery. You can see here, maybe vertebral artery in the posterior area, we doing the cervical foraminotomy. Maybe if we doing foraminotomy very aggressively, very close to the vertebral artery. You can see here the this actually this is kind of not human beings. And anyway, after sufficient foraminotomy, you can see the some red color area. This is vertebral artery. This vertebral artery very close to the nerve root area. Because of that, if you doing the aggressive foraminotomy, you should give the caution to the vertebral artery damage. Some of the doctors, I already heard that maybe some doctors they injure the vertebral artery, but sometimes that is very danger, but sometimes very lucky. Anyway, to keep the safety, vertebral artery is also a very important point of cervical posterior foraminotomy. And also clinical results, we already so many paper published. This is my paper published in the European Spine Journal, and in the with the 2-year long-term follow-up, the clinical result is very good. And you can see this conventional cervical posterior foraminotomy, not PPPV, and anyway, in spite of that, the clinical result is very nice. And also in another paper published by me, you can see the World Scientific paper, Journal of Musculoskeletal Research. You can see here the generation 1 is open surgeon generation. Generation 2 is endoscopic generation. Then nowadays open generation 2, how much endoscopic spine surgery increase? You can see near approximately 90% of spinal cervical pathology managed by the posteriorly. But more importantly, you can see here this is more important. Maybe in the generation 1, in spite of the HDP, the patient result is very nice. You can see 96% of good to excellent. This is generation 2 also similar, maybe 97% good to excellent. But different thing is that the excellent result is more many in generation 2. It means that in spite of the good, the pain solving after HDF, the patient is still not completely satisfied their result. If we doing the cervical posterior foraminotomy, the excellent result, we can take a more higher, more many patients. Now this is very interesting images. You can see this case and this case and this case, this case, all it looks like similar, but the operation is completely different. This HDF, this ADR, these two patients, in spite of the same patient, the patient received the cervical posterior foraminotomy, and the cervical motion improved more sufficiently. And also, fortunately, I already mentioned that if we doing the cervical facet, also very important in the open surgery, because of we know that in the cervical area, more than 40% of facet damage may be some higher chance of instability in the previous paper. But in the endoscopically, in my study, maybe more than 60 or 70% have no problem of instability. And also some additionally more important point is that then make remodeling happen in the cervical area. You can see this is very interesting because of that. You can see, okay, this is first post-operative, and maybe this 6 months, maybe this 1 year. Anyway, the facet joint also regrowth, and then the you can see like this regrowth, and then stability keep again. And also you can see, wow, this patient is very digested, because you can see the approximately maybe 100% fast damage. What doing for this patient maybe 2 years? Yeah, this 2 years later, X-ray and CT image. What happened? Because of that, in the cervical endoscope procedures, keep the paraspinal muscle not only, but also keep the skin, but also and keep the another structures that make keep the tensegrity completely. That is very important to keep the stability. Actually, I'm doing so many cases of foraminotomy, but nowadays I'm don't worry the instability, rather than the focus to the sufficient foraminotomy to solving the problem foraminal decompression, rather than the keep the stability, keep the facet joint. Because of that, I already study, but sorry, but paper still not published that. Anyway. I will show some of cases. So you can see maybe this C3-4 cervical disc. This is not in the anterior cervical approach, but this patient have a so severe pain, and maybe okay. After first foraminotomy, and then you can see here is a. Can you see this pedicle? Partial pediculotomy, and insert the small working channel, and then the disc also drilling done. Now you can see the some traction, some more safely. This is a disc. And then you can see the protrude disc here. And after then the patient's pain gone completely now. And another case is C5-6 huge disc patient. This patient also have a so severe pain, 28 female patient. And after maybe foraminotomy, now you can see that here is pedicular area. Then some foraminal ligament resection. Then you can see the partial pediculotomy and vertebrotomy image. You can see cortical, cancellous and cortical pedicle area. After then, we can retract more safely from the caudal tube cranial. And then insert the working channel and traction is possible. Then you can see the protrude disc, rupture disc here. And additional partial vertebrotomy done, and then finally near complete decompression to here like this. And also another case, this patient came to with a shoulder drop due to C4-5 huge rupture disc, and after maybe now you can see cervical foraminal ligament here, and after cutting the foraminal ligament. Okay, now partial pediculotomy done, and traction, and this nerve root, motor nerve root here, and remove the rupture disc from here. Huge disc here. And this post-operative, and this 3 months later, the patient shoulder drop recovered completely now. And also this patient, C5-6 huge rupture disc, very younger girl. She's a dancer, but she cannot play she's job due to shoulder drop, maybe. And also you can see here partial pediculotomy, and this very close above the pedicle area, huge rupture disc from here. And then the patient rupture disc disappear, and the patient shoulder drop also recovered completely, and she returned to she's normal, she's job dancing again. This case is also very interesting case, because this case is C71 severe foraminal stenosis. Okay, I will explain all things. This is C7T1. Now this SAP, this foraminal nerve root here, this tip of ligament of SAP, and you should always open the tip of the SAP, because there is a landmark of the medial border of the lateral border of the pedicle. After resection of SAP from the tip of the SAP, you can match the lateral border of the pedicle area, then remove some partial bone. Now you can see this foraminal ligament, and here is pedicle. And then I already done the partial pediculotomy, and now insert the retract and working channel as a retractor, and then move to the more cranial. Now doing the partial vertebrotomy, and then with the partial vertebrotomy, the uncovertebral joint resection is possible, because of that. The foraminal stenosis also can manage more safely in the posterior approach. This is final point. Still preserve the foraminal ligament. Here is a nerve root. Here is a safe foraminal lateral border of the pedicle is a final point of the foraminal area here. And after then, You can see postoperative image like this. This case is also very interesting cases. This case, at this month, James paper, you can see this case paper. This patient came, a 72-year female patient with, you can see here the spondylolisthesis 5, 6, and 6, 7. And here you can see, and the severe foraminal stenosis 5, 6, and 6, 7. But unfortunately, this patient received previously carotid angioplasty here. Because of that, anterior approach is not possible. But we should decompression this 2 point of C5, 6, and 6, 6, 7 totally. Because of that, I resected this 6 pedicle complete resection. You can see here. This C6 pedicle. Totally resect the C6 pedicle by the endoscope drill. Then here is a pedicle. Here is a C5, 6 foramen. Here is a C6, 7 foramen. Now you can see the contour of the pedicle. Around the pedicle, here above point is C5, 6. Caudal point is C6, 7. Yeah. Then the patient 2-level decompression was done, and the patient pain gone completely, and she followed more than 3 years. Have no pain still. Yeah. In conclusion, maybe at the initial time, I'm talking that maybe with the development of this cervical foraminotomy, not only conventional V-point foraminotomy, but also partial pediculotomy and partial vertebrotomy. Maybe recently, I'm doing the more than 95% of cervical pathology by the endoscopic, not open, and also keep the tensegrity with some minimized damage to the skin, muscle, and facet joint, and all things that make a real preservation of the spinal segment and restoration of spinal alignment. That will be the with this overcome this cervical thoracic pathology and endoscopic lumbar interval fusion. That after then the generation changed from the open surgery to endoscopic spine surgery. Thank you for your kind attention.
Thank you so much, Professor Kim. It was a great lecture indeed. And please, can you stop your screen sharing for now?
Okay, sorry.
Okay. And unfortunately, Madonna had a medical emergency regarding her father. So I am gonna moderate the meeting from now on. And now I will share a link from the chat part. Now, okay.
Yunus, I didn't ask about that.
Professor Kim, sorry. First, I will share a link from the chat part, and we will ask a question. And as İzmir Online Neurosurgery from now on, 3 people who attend all endoscopic spinal conferences, surgery conferences, and who will correctly answer a question to be asked at the end of each conference will be given the right to attend to endoscopic spinal surgery course free of charge. In addition, the 3-day accommodation of the participants in İzmir will be covered by us. Don't miss out. And if anyone click on the link, they will see the question and the answers. And if they click the right answer, they will win the prize. And I see Professor Yunus Aydın ask a question and comment. Maybe he want to ask himself briefly. Professor Aydın.
B?
No.
You took.
Professor Aydın write a question.
Yes.
And write a comment. Maybe he can want to ask himself briefly. Okay, Professor Aydın.
Hi, Dr. Kim. Congratulations. It was an interesting topic. I have a minimal invasive contralateral cervical discectomy technique with a microscope, and I did 3,000 cases. I had experience also on posterior approach. Your described cases, interesting. You are compensating the endoscopic technique with removal of the pedicle and foramen, and then you can look under the root and clean the fragments. But even with this approach, you have limited approach, and the rest of the nucleus stay. Some of them degenerated and can be mobilized after surgery. How many years follow up, and how is your recurrence rate? First, also.
Yeah.
So
yeah. Thank you so much. Maybe I'm done maybe cervical posterior foraminotomy more than 5 years, and I have so many cases followed more than 2 years. But I commented maybe 300 cases of cervical foraminotomy. There is some only in Nanuri in Gangnam Hospital, not Nanuri Seoul Hospital. Maybe I'm started from Nanuri Gangnam 2018, 8, 9, 10, 5 years maybe. Among them, maybe recurrence cases, maybe one case is of recurrence, and one case is maybe have some fusion cases, but that case is preoperatively, the patient also have a instability because of that. Truly aggravation of instability not happen, but recurrence is one cases. The patient also doing again cervical posterior foraminotomy.
same technique, same approach.
Yeah.
The most interesting things I got from your lecture, you say this stability comes from also not only from these bones and ligaments, comes from also soft tissues, but especially the muscles and ligaments. This is I totally agree with you, because in my technique, anterior contralateral approach, I do some uncal foraminotomy, but don't touch the end plates and the other sides. And after surgery, we don't have any instability. And after postoperative MRI, you cannot discriminate which level operated. So our experience more than 30 years. I don't know if you read my paper or not, but posterior approach, I use conventional technique. That's limited, but really good. Against if we compare it the fusion techniques, it's a great advantage. If you do 2 levels, if you 2 levels, do you change your entries? Do you do 1 entry or 2? Did you do 2 levels discectomy?
Yeah. In the cervical area, the skin to target point is very long distance. Because of that, usually one skin can possibly maybe cover 2 or 3 level. Maybe it means that the 3 level cervical foramen need one skin is only. because the two level also same only one skin incision. But
One skin, yeah.
because of that, insert to the hemobag. Hemobag is very important in the postoperative management. Because of that, should insert the many. Because of that, I'm not using the some. I insert to the hemobag and insert working obturator again. Another level.
And also, your picture was very clear, bloodless. But we know there are some venous structures, and also you are doing bone. You are removing the bone and it causes some blood. How are you handle the blood hemostasis blood issue?
Yeah, that was very important question. Thank you so much.
Yeah.
Yeah. In the you saw the my operation cases, but in the cervical foramen, but most maybe difficult point is that some venous bleeding. So many open surgeon, endoscopic spine surgeon, but that easily managed by the compressive approach. You can see I'm docking the working channel and move again with the compression. Because of that, in my case, bleeding is not so serious. Usually, there are so many cases I have met the problem of venous bleeding. They all easily manage it with the compressive approach. Yeah.
Compressive approach. You don't use any additive surgical or
maybe in the cervical, in the lumbar area, sometimes use some flow shear, but the cervical area usually.
There's no space here. I know. There's not much space here.
Thank you, Professor.
Okay. Thank you. Thank you.
Nurullah Kösmene from my hospital resident says, thank you, Professor. It was a great lecture. Dr. Nurullah Kösmene, İzmir. By the way, I want to talk about the answers.